Dr. Adanna Anyikam is a consultant in maternal fetal medicine. That means she specializes in high-risk pregnancy and obstetric ultrasound, board certified by the American College of Obstetrics and Gynecology, maternal fetal medicine, and general obstetrics and gynecology. She holds the current position. She's the founder and owner of Optimum Obstetric Imaging Consultants in Lagos, Nigeria, as well as a consultant, maternal fetal medicine, Baptist Health Hospital, Kentucky in the USA. She had her maternal fetal medicine fellowship from the University of California, San Diego, obstetrics and gynecology residency program from Westchester Medical Center, a doctor of medicine from University of Texas School of Medicine, Masters of Public Health from Yale School of Public Health, and a Bachelor's of Science in Engineering. I'm going to invite Dr. Anyikam to give us her much anticipated presentation. Over to you, Dr. Anyikam.
Good morning, everyone. Thank you for joining. I'm in the US now, so it's a bit early, but I have my coffee, so I'm ready. As Dr. Njoku was saying, that this is a very sensitive topic. And so some of the things that I'll discuss, let me start the slideshow. Some of the things that I will discuss here, possibly you already know, but it's very good. Hold on, let me try to move this up.
Yeah, it looks good, Dr. Anyikam. If you could just speak louder.
Oh, okay. So some of the things that I'm gonna, can you hear me now? Is it better? Is it better now?
Yes, the screen is good.
Okay, so some of the things that I'm gonna discuss here, you may already know, but considering that recurrent pregnancy loss, recurrent miscarriages is a very sensitive topic and it can be a very complicated topic. So hopefully with this discussion, you'll be able to better explain to the patient what's going on and what you plan on doing. So thank you for allowing me to speak this morning. Okay. So before we start anything, we have to kind of consider our options. What are our objectives? And the first objective is we have to really define the problem. You as a healthcare provider has to understand what the problem is, and then you have to define the problem to the patient themselves. And so we need to know the definition of recurrent pregnancy loss, and I'll use RPL or recurrent pregnancy loss interchangeably. Additionally, the next step is to then understand which are the different causes, because there's many causes that cause a woman to have several miscarriages. And there's some background noise.
And can you mute everybody?
Okay, sometimes we have technical difficulties, but it's okay. So we need to know the definition. We need to figure out the different causes. Then we need to determine when the patient comes in, how to work up different patients that have different presentations. And then the most important thing after now, especially when people are trying to figure out why this keeps happening, is to create a management plan for those different causes. So sometimes one patient can come into your practice or your clinic or your office, and you don't really know where the patient falls in. So the first question is, can we identify the recurrent pregnancy loss case? This patient, let's duplicate her 3 times. So the first time she comes, the first option is a person who has a vaginal delivery preterm at 32 weeks and the baby is alive. In 2019. 2015, she has a preterm delivery at 35 weeks, the baby's alive. Is this person a person who can be identified as recurrent pregnancy loss? That's a question. The second patient, she looks similar for the first, but she's had a miscarriage at 8 weeks, then a miscarriage at 17 weeks, then a vaginal delivery term live birth in 2008. If this patient came to your practice, your office, or your clinic, would you call her recurrent pregnancy loss? And the final one, Patient 3, she's had many pregnancies, a miscarriage at 13 weeks, 3 vaginal deliveries, and then she terminated her first pregnancy electively in 2006. So if these 3 presentations came across your desk, which one would you call recurrent pregnancy loss? So I hope everyone looked at this and determined that patient 2 actually is the one that has recurrent pregnancy loss. And going through this lecture, everyone, if you didn't answer 2, by the end of this lecture, everyone should be understanding what recurrent pregnancy loss is. So we'll go straight to the definition. So defining recurrent pregnancy loss. If you look at the European consensus, the US consensus, and different consensus societies, obstetrical around the globe, they actually make this definition very vague. It's not specific at all. The only thing that specifically they discuss is 2 or more pregnancy losses spontaneously that are diagnosed by blood pregnancy test or a urine pregnancy test. And if you notice in this definition, they don't say if it's beyond 20 weeks gestation, 5 months, or before 20 weeks gestation, 5 months. But it's okay having a vague definition because we'll still have a complete understanding by the end of the lecture. So you can have different presentations, but it's easy to classify them into 2 categories. Primary recurrent pregnancy loss is a woman such as patient A. She's been pregnant 3 times and she's had 3 miscarriages, no live births. So this is a loss in women who have never carried beyond 24 weeks. Secondary recurrent pregnancy loss is patient B. She's a bit older, she's had more pregnancies, but she has some live births. So her first 2 pregnancies unfortunately ended in miscarriage. Then she's had 2 live births, and then finally the latest pregnancy she had was a miscarriage. So this is a loss of a woman who has previously had live births. Now, in this talk, we'll be using the terms miscarriage and spontaneous abortion interchangeably. This is important because as clinicians, as healthcare providers, nurses, community health workers, doctors, we know that spontaneous abortion is any loss at or before 20 weeks. But the term abortion is a very delicate term. So when you're talking to women and when women talk to each other, they usually use the word miscarriage. But just so you know, we will be using it interchangeably in the lecture. Okay, so these are some of the patient case summaries that we'll be reviewing when we're looking at the different presentations. We'll have 6, and throughout we'll touch base on each one and explain in detail how these individual cases are different and how to manage them. Okay. So the causes of recurrent pregnancy loss. Everyone on the call who's a healthcare worker probably knows that this is a very, very broad topic. And understanding where to start, sometimes your head can spin a bit. There's a lot and many causes of recurrent pregnancy loss. And this is the gestational age scale, but any of these causes can happen at any point of time in the week's gestation, and they can actually go on beyond 20 weeks, maybe 21 weeks, 22 weeks, 23 weeks, 24 weeks. What we need to also realize is that if you rule out all these conditions, a lot of recurrent pregnancy loss cases are unknown. We don't have an exact understanding why. But let's talk about we'll talk about chromosomal problems, structural problems, which are problems that are involved in the body of the uterus themselves, a clotting disorder that people may or may not have heard of, maternal conditions, poorly controlled sickle cell, diabetes, thyroid, infections. Now, infections are very curious because if you read the literature, there's really no consensus that infections can cause recurrent pregnancy loss. But at the same time, you want to get rid of infections and have a clean slate and try to help women. And we'll also talk about cervical insufficiency or cervical incompetence, RH incompatibility is a long lecture that we can spend 3 hours talking about, but we'll just talk about it briefly, how we can rule it out. And extreme poor nutrition in some settings can cause recurrent pregnancy loss. So where do you start? Is it everyone? You'll start from chromosomes, every single thing that I talked about, all the way down to unknown causes. Well, we have to triage patients and figure out who fits where. So the first step is we need to obtain a detailed patient history. The patient history, as we all know, will give us clues to figure out where we can start in this spectrum of options. For instance, for chromosomal, if a woman is continuing to have miscarriages, and they're usually before she goes to ANC, before she books, maybe she has a miscarriage by 8 weeks and then by 10 weeks. Are they all at the very beginning of the pregnancy? Did you rule out other causes? Is she of advanced maternal age? Structural, we have to think about, okay, does she have an enlarged uterus? That we'll think of fibroids. Or does she miscarry? She carries a pregnancy to about 8 weeks, then she miscarries, then she carries a pregnancy to 16 weeks, then she miscarries, and then her last one is about 22 weeks. Does she get further and further along in the pregnancy, and then she miscarries? This has sort of a situation, maybe it's structural. And does she have a history of multiple DNCs? And because this is an international and a global conference, a lot of places, an elective termination is still illegal. So women are going to places that are unsafe and unsanitary to have terminations, and that can cause scarring in the uterus. And there's a lot of other things that we'll talk about that can point us and kind of key us into maybe this is a problem that is structural. Antiphospholipid syndrome is a very complicated syndrome that involves clotting, deep vein thromboses. Someone who has this history plus recurrent miscarriages can lead us towards working up in this line. And as we were saying before, does this woman have other medical problems that are untreated? Then this could be a reason that she has recurrent pregnancy loss. Infections, if she has a history of infections. Cervical insufficiency. This is something that sometimes confuses practitioners, and sometimes practitioners know that this is a problem, right? And it's very obvious. So with cervical insufficiency, unlike structural issues, structural issues are specifically talking about the uterus. Cervical insufficiency is looking at the cervix, which unfortunately shortens and then opens early in the pregnancy. So does this person have rupture of membranes, leaking of glycol, advanced cervical dilation? Maybe she's 5 centimeters by 20 weeks. Things like that will kind of think about maybe it's a cervical case. And of course, RH incompatibility, that can easily be checked by a lab. So knowing these things and knowing what to ask about a patient as you're listening to her story, how do you initially assess the patient? So, sorry, let me turn off my alarm. Okay, so going back to patient B, she's had 3 miscarriages, 2 deliveries, but we need to know more information about these miscarriages. So we need to obtain a detailed history. Ideally, we should ask these questions of patients, but we know that sometimes when we ask questions, the patient will not respond with all the answers that we need. But ideally, we should get a clear menstrual history. Did they have a positive urine pregnancy test for each pregnancy? Sometimes this is documented that the patient has it. Sometimes they don't. Do they have a positive blood test, pregnancy test for each pregnancy? Now, if a woman is losing miscarriages before they book at the antenatal, sometimes they won't have documentation of a positive blood test in pregnancy. Do they have an ultrasound showing that there was an actual intrauterine pregnancy for pregnancy for each pregnancy? Ideally, that should happen. And then documenting how many months, how many weeks was a woman before she miscarried. So in this ideal patient, she says that she has regular menses each month. All her miscarriages, she had a positive pregnancy blood test, and all her pregnancies had ultrasounds. And sorry, let me move this. And in this ideal case, she can tell you 2006, she had 4 antenatal visits. She miscarried at 12 weeks. Then 2009, she had 4 antenatal visits. She miscarried at 18 weeks. 2018, she had 2 antenatal visits. She miscarried at 22 weeks. Now, this is a complete hypothetical patient, because this patient is giving us all the information that we need. But we need to know, in reality, when a patient comes and we're obtaining a history, typically they can have miscarriages without actual blood confirmation or without ultrasound proof of pregnancy. So we may not know exactly how far along they were before they had their loss. And if she has a history of irregular menses, sometimes you have to really try to elucidate, was this an actual pregnancy or was it her menses? So it can get a little confusing. So that's why you have to really take time to kind of get as much information from the woman initially as possible. So for her, she doesn't have a medical history background, no diabetes, hypertension, sickle cell. All of her miscarriages were passed medically, meaning when she came in and presented to the antenatal clinic, they did an ultrasound and there was no heartbeat on the ultrasound. So they gave her medication so she can pass the pregnancy. She's never had any elective terminations, and so she's never had any dilatation and curettages. And her husband is about the same age as her, 39 years old. So when people present with consultations to my office, we typically do a pregnancy test. Today, this patient is not pregnant, but she really wants very good counseling before her next pregnancy, because while a lot of the causes of recurrent pregnancy loss can actually be causes of fertility and infertility in women, these women with the recurrent pregnancy loss can easily find themselves pregnant, unlike the fertility clinic patients. But the problem with the recurrent pregnancy loss patients is that they can't hold on to the pregnancy. So she knows that she can get pregnant, but she's very cautious about getting pregnant because she doesn't want to experience having another loss. So we create a problem list. So she has secondary recurrent pregnancy loss because she's had live births. She also has a history of preterm delivery, which is also interesting, and she's of advanced maternal age. So when we come up with the differential, we can't start with that cause of pregnancy list and start from the top and go all the way down. We have to figure out which one of those are most salient to her. So it could be chromosomal, maybe structural. I'm more in tune to look at that, and maybe antiphospholipid, but I don't really see any clotting. She doesn't have any history of clotting and things like that. And because the antiphospholipid syndrome labs are quite expensive, it's good to keep that in mind, but rule out other things that are easier to rule out. The unlikely differential, RH incompatibility, we can easily do an investigation to rule that out. She doesn't have any maternal conditions. Now, why did I say that cervical insufficiency is unlikely? Because with cervical insufficiency, it's like the woman's body is going into labor early. The cervix starts shortening and starts opening. For her, she just presented to the ANC visits, had an ultrasound, and there was no fetal heartbeat on the ultrasound. And they had to induce the miscarriage with medicine. So her body's not going into labor. So it's unlikely that it's cervical. And she doesn't look like she has nutrition issues. So for every single patient that we are looking at and working up, we always start with the basics, the detailed patient history, then we do a physical and a pelvic exam. The labs that we can do will differ and depend, but you always want to rule out Rh incompatibility, and that can be easily done with blood typing. And for her, we add on the ultrasound as well to see what exactly her uterus looks like. So the ultrasound shows a normal sized uterus, no adnexal masses and tenderness. She's Rh positive, she doesn't have any antibodies, but the ultrasound is suspecting a uterine septum. And this is what a uterine septum looks like. If you think about, and this is how I describe it to patients, you think about your uterus like a room with 4 walls. And for some reason, there's a divider coming in between the room, and it doesn't touch from one wall to the other. It stops halfway. So now the room is kind of divided into 2, and that's a uterine septum. So with structural issues, we can touch on 3 highlighted points: uterine malformations, fibroids, and uterine adhesions. This is a normally formed uterus where there's no septum, the walls of the uterus are well perfused. And so when the fetus now implants and attaches to the side wall of the uterus, because of the good blood flow, the fetus grows normally and you have uncomplicated pregnancy. When you have a uterine septum, this septum here, this divider that is going inside the room, dividing it into 2, the blood flow on that septum is not very good. So if the fetus implants on the septum, there's a high likelihood that as the fetus grows, it will outgrow the blood supply and result in in a miscarriage. And so we remember this woman, she's had 5 pregnancies. And so 3 of them have ended in a miscarriage. So it's likely that the children that are living, when the fetus implanted, it most likely didn't implant on the septum. It implanted on the other areas of the uterus. Now, a uterus malformation, a congenital anomaly, Mullerian malformation, they're all called the same thing. This happens when the woman was formed before she was born. And the uterus can be shaped abnormally in different ways. For each one of these, whenever the fetus implants, if it implants on the side wall or on the part of the uterus that is poorly perfused, that increases the chance of a recurrent pregnancy loss. Additionally, as you can see, it also can increase the risk of preterm delivery. And if you remember, this patient had 2 live births that were all preterm. And because of the way the uterus is shaped, you can have a breech delivery. The head will not normally descend towards the end of the pregnancy. And there's also a risk of intrauterine fetal growth restriction, as in a low birth weight baby. Now, any woman with structural problems, it is not 100% that they will have recurrent pregnancy loss. Some women with uterine septums, they have 2 planned pregnancies that are successful. And then we'll talk about fibroids. Some women that have fibroids never have recurrent pregnancy loss. Someone with uterine adhesions don't have issues. So it's not that these structural issues is a guaranteed sentence for recurrent pregnancy loss. But if someone is having recurrent pregnancy loss and they have these issues, it's likely related. So what can you do? So remember, the patient wants to leave your office. She wants to leave the clinic with an idea of what her problem is and how she can solve her problem to actually accomplish her goals. So for a woman who is seeking a pregnancy that will end successfully, that has uterine malformation, specifically uterine septum, we need to do preconception management. We need to send her to a specialist that can do surgery to remove the septum. And removing the septum will increase the chance of the fetus implanting on well-perfused areas of the uterus to grow and successfully be delivered. So fibroids, we in Africa, we are all familiar with fibroids. Fibroids have an increased risk of different obstetrical outcomes. So with this patient C, she's had a vaginal delivery at 40 weeks, almost 20 years ago. But since then, she's been trying, she's gotten pregnant recently, and unfortunately, she's had 2 miscarriages. So for her, we still do a detailed history. She doesn't have any medical problems, nothing. Then we'll do the initial workup, which is the physical and the pelvic exam. Baseline labs will do as well. Her ultrasound shows that she has uterine fibroids. Now, as practitioners, we all know that uterine fibroids can be multiple, or they can be 1 or 2 in key locations. Why does fibroids, or why can fibroids cause recurrent pregnancy loss? Well, as with many things in medicine, the mechanism by which fibroids cause spontaneous losses is unclear. We have a kind of idea, because we know if you have 100 women with fibroids, it's not 100% of them will have recurrent pregnancy loss. It's not 100% of them will have bleeding at the end of the pregnancy or preterm delivery. Fibroids can interact and cause problems in different ways. What we're thinking is similar to the poorly perfused areas in the uterine malformations, is that when the fetus implants, possibly the fibroids can compromise blood flow specific to the area of the placenta. It can cause significant early bleeding. We know that fibroids, as the uterus grows, can cause pain because of inflammation released by the cytokines. So something about the interaction of the fibroids, the cavity, the placenta, the growing fetus can cause an increased risk of spontaneous abortion. Now, likely it's fibroids that interact with the cavity or are close, or intramuscular or close to the cavity. If you have a pedunculated fibroid that's sitting outside of the uterus and attached with a stalk, you probably won't have these problems. So again, when a woman comes, you finish the workup, you look at the ultrasound results. What is the next step? Well, if she's continuing to seek pregnancies, what you want to talk to her is that preconception management. You cannot remove fibroids while a woman is pregnant, and you should not, because it's contraindicated. So she needs to look at having fibroid removals now that she's not pregnant, in anticipation for her future pregnancies. And so the last structural issues that we'll talk about is something that is commonly seen. And I'll talk about how to get more information from a patient. When I was running a fertility clinic last year, it was a free fertility clinic that I was running in Lekki. A lot of women were coming in just like patient D. She'll tell me 2019, she had a miscarriage very early at 8 weeks. 2018, she had another miscarriage. And I would say, but okay, how many other pregnancies? She was like, these are the only pregnancies. So, but once you start gently asking and pulling out information, they'll now tell you, she'll now told me that okay, fine. When she was much younger, she had 4 voluntary terminations. She had 4 abortions. And this is important because that means she's exposed herself to DNCs, and that can increase the risk of structural issues. So given that history, same workup that we did, labs, exams, ultrasound. The ultrasound, and she wasn't pregnant when she's not pregnant. So the ultrasound just showed a normal uterus, 8-week size. But when you have a patient that's had multiple DNCs, okay, maybe let's say that it's a different patient and she's had 3 miscarriages, but the clinic had to do a DNC because she had a lot of retained products. When you have someone with a history of many dilatations and curettages, what else can we do to visualize what's going on in the uterus? So the ultrasound can look at the structures of the uterus, but we need a method where you can fill up the uterus with liquid and then look inside to see if there's any scar tissues. So in this fertility clinic that I was running, the women would come in with their x-ray films. So the most accessible, you can do an ultrasound where you can inject a saline into the uterus, but the most accessible one, because they're doing it at different radiological centers that was in my area, is a hysterosalpingogram. And this hysterosalpingogram, the radiology center injects a dye into the uterus, and that fills up the uterus, and they take an x-ray. And then they give that film to the woman. So when they were in the clinic, I would pull up the film and I would look at it and I would see how well the dye travels through the uterus and spills out into the tubes. And this gives you a clearer picture, a different picture than an ultrasound. So for anyone that is familiar or not familiar with the hysterosalpingogram, this is what the film would look like. So in a normal uterus, the dye, which is the white color, fills up the uterus and it looks like an upside down triangle. And then if the tubes are patent, the dye spills out of the tubes and into the adnexa. So this is a normal appearing uterus that doesn't have any scar tissue or any intracavitary lesions. Now, comparatively, this is a film of where this is the probe that they're using to inject the dye. And the uterus is filled up. Now, the places that are not filled up, that is a filling defect. So that lack of dye, the black areas, can be indicative of scar tissue. After all those DNCs, the insides of the uterus became inflamed and angry and created scar tissue. So having this film highlights that this woman has intrauterine adhesions, scarring. That is a problem. So again, this is just a drawing of what it would look like. It would almost be like if you kind of think of cobwebs inside of the uterus. So if we're thinking about the intrauterine septum, the fibroids, again, when the fetus implants, it can implant in those areas of the scar tissue. Again, those areas are polyperfused. So these women, they don't have an implantation problem. The fetus successfully implants where it can. But as it grows, the tissue around it is so poor that it results in a miscarriage. And again, we've identified the problem. What is the plan? Again, this is a preconception plan because we need to get the uterus in order before the next pregnancy. This cannot be solved while there's a growing fetus inside. So again, these women need to be referred to a specialist that can now do a hysteroscopy, which is putting a camera inside of the uterus and looking inside of the uterus and gently removing the scars. In areas where they don't have hysteroscopies, they can also do intrauterine therapies. They can put a catheter into the uterus, expand it, and then also estrogen therapy. And I personally don't do these construction problems, but there's different specialists that can decide which option is best based on what is presenting. So structural issues, we know, preconception management. It's best to catch these women before they have their next pregnancy, if we think that the structural issues are the main reason why they're having the recurrent pregnancy loss. So moving on, we have a younger patient. Unfortunately, she doesn't have any children at home. So again, we obtain a detailed history. We know that she doesn't have any medical problems, no other issues. But we still want to know a little bit more of what was going on around the time of these miscarriages. Her first pregnancy, she presented to the clinic. She was very crampy. They did an exam. Her cervix was 5 centimeters dilated. She eventually had the miscarriage. Her second pregnancy, she had loss of liquor. She came to the clinic. She was dilated, and unfortunately, she delivered too early at 22 weeks. The most recent pregnancy, and you'll see this happening a lot in our women, she didn't go to the ANC. She didn't book at the ANC at all because she was that fear and that dread of things that were happening in her previous pregnancy. So in this patient, when she missed her period, she waited maybe 1 or 2 months before she took a home pregnancy test. Okay, and it was positive. So now she's possibly around 8 or 9 weeks when the home pregnancy test was positive. Then she bled 4 weeks later. So she was well into probably being 3 months pregnant when this happens. So a lot of times you'll have women that they'll have detailed information maybe over their first pregnancy or their second pregnancy, but they may stop going to clinic after because of fear. So today she's coming in because she knows she's pregnant and you confirmed it. And now we need to figure out what is the likely cause of her recurrent pregnancy losses, because now the clock has started because she's pregnant. We need to figure out how far along she is and what we can do to help achieve the most successful outcome possible. So the same thing, the same workup, but additionally, we do routine ANC booking labs. The ultrasound and the pelvic exam are similar. She's about 16 weeks along, about 4 months. But what's interesting is that when we do a cervical length on the ultrasound, her cervix is only 1 centimeter. So when I'm talking about a cervix with women, especially depending on the educational level of the women, and I mean, even if women have higher education, it's not everyone that was paying attention during science classes. So typically in the literature, they can talk about cervical insufficiency, cervical incompetence. I personally stay away from the term cervical incompetence because it makes women feel a certain way. So when I describe cervical insufficiency, it's the inability of the uterus to retain a pregnancy to term. So I usually show them a picture like this. This is a cervix, this is the uterus, and the baby is inside of the uterus. The cervix is down here. I tell them to think of your uterus as an upside down Coke bottle, okay? That's how it looks. The neck of the uterus is called the cervix because the cervix in Latin means neck. So think of the cervix as this part, right? So, and that's how we measure it. So we measure the length, and then when you're in labor, we measure how opened the bottle is. So typically they have a better understanding when I explain it like this. And so I tell women, so when you are approaching your due date, usually 37, 38, 39, 40 weeks, in a normal pregnancy, that cervix, that neck of the uterus starts making dynamic changes. It starts shortening, gets shorter, 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 and then it starts opening, 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 and then you deliver. You become 10 centimeters and then you deliver. This is a normal process of shortening and opening as the baby descends and you deliver. And that is kind of the rudimentary understanding of labor. However, when your cervix is insufficient, when you have cervical problems, something happens around the mid-trimester. This is very early, too early in the pregnancy, around 3 to 5 months, where your cervix starts shortening. A short cervix is a cervix that's less than 2.5 centimeters. And we can show this as a normal cervical length. And we can see as the cervix shortens, there's an increased risk of it now opening. And now if it opens, that's a problem. So I show them the Coke bottle as well. So the normal cervix is long. For example, this one is 3.7 centimeters that we measure with the ultrasound, and it's closed, versus this one that is 1 centimeter, and now there's a risk of it actually being open. Why is that important? Well, everyone has bacteria, which is this yellow symbol in their vagina. Normal bacteria, just the normal flora of the vagina. That bacteria of the vagina has nothing to do with the uterus. So if the bacteria wants to go up to the cervix is closed, it's long, it's a barrier protecting all the contents inside of the uterus. However, when you have a short cervix, and it's silently shortening, so you don't know it's happening. When you have a short cervix, it shortens and then it dilates and then it opens. So now that bacteria, and this process has probably been happening over days and weeks, but now this bacteria can enter the uterus, which is not good. And once that bacteria enters the uterus, weakens the lining of the amniotic sac, infects the uterus, the patient will now have cramping, bleeding, loss of light, or rupture of membranes. So this process silently happens until you become symptomatic. And it results in a miscarriage when it's very early in pregnancy. So with this patient who is very fearful because she's had very hard pregnancy history, now her cervix is 1 centimeter. This is a short cervix because it's less than 2.5. So we know that she has a risk of her cervix now opening, dilating, and delivering the baby too early. So what we offer these patients is a cervical cerclage. And a cerclage is like a French term. It just means a string. So it's a surgical procedure where they tie a suture around the cervix to keep it closed and help slow down further dilatation, or slow down further shortening. Now the cerclage is not going to completely prevent the cervix from shortening and opening, but it can reduce the risk of the cervix shortening and opening. It slows down the process. And you can see this is the vagina, and this is the bacteria that's normally there. And so now the cerclage will help prevent entry, because that cervix will still now form as a barrier for those bacteria. And I kind of just show them this. It's like now the neck of the bottle has shortened, but then we tie it and we block it from further shortening from all of the bacteria that can actually go in. So in women with histories of mid-trimester losses, that sounds like a cervical issue. You can, once they become pregnant early in the pregnancy, you can do a prophylactic placement of a cerclage. Or you can follow these women every few weeks looking at the cervical length, and then place a cerclage once the cervical length is short, less than 2.5 centimeters. So if this woman, for instance, she booked at 8 weeks, that's too early to put a cerclage, because the lower uterine segment and the cervix area is not developed enough. So typically we don't do it before 13, 14 weeks. But because she's 16 weeks now, her cervix is short, and she's had that history, we know that she's at an increased risk of a loss. So for her, definitely I would recommend a cerclage, plus vaginal progesterone that she would put deposit as a suppository nightly. So there's a lot of information, but we'll summarize as we get through this lecture. So structural issues that are problems with the uterus, it's a preconception management. It usually deals with surgery and intrauterine interventions. Cervical insufficiency, That is ultrasound surveillance and cerclage placement. That is during pregnancy management. So now another patient comes in, our third patient. She's had miscarriages twice, and she doesn't have any living children. Same thing, obtain a detailed history. We have to really sit down and listen to patients. And with her history, we're finding out very interesting things. So she tells us that she has sugar problems. She's on the heavy side. And it's like she's had sugar pills. We don't really know what, it seems like she's diabetic and she was on medication. And she's had miscarriages early in the first trimester and then towards the second trimester. Today, she's not pregnant, but she wants counseling because she's very fearful that this can happen again. So including the initial workup that we were doing with the other women, we'll add diabetes labs. We'll check her glucose and do her A1C and check her thyroid as well. These are easy and cheap investigations that we can do initially. And as you can see, this woman is a classic poorly controlled diabetic. Her random glucose is high. Her A1C is high. So it's a very straightforward case. What we need to tell her is that, Madam, your sugar problems are an issue. And it seems to be affecting keeping your pregnancy. So we need to have strict management of your diabetes. You need to be on strict medication. You need to have good follow-up. And when we can bring the A1C down and control the sugars, then we can try again for the pregnancy. So whether the patient is a diabetic or they have hypothyroidism or lupus, or they're a sickler that has many multiple crises per year, we want to control these medical problems and optimize the patient before they try to get pregnant. So ideally, this is preconception counseling, but is life. Sometimes these women, especially my diabetic patients, they'll come in with a history of 2 or 3 or 4 losses, and now their A1C is about 10, and they're in the first trimester. So we have to aggressively treat the diabetes in the first trimester to try to gain more and more time and have a successful pregnancy. So for infections, again, it's very unclear if infections really contribute to recurrent pregnancy loss, but we should always test, do blood tests and cervical swabs, and treat them accordingly. And RH incompatibility, isoimmunization can cause recurrent pregnancy losses, but this is a very straightforward investigation that we can rule out in every woman. Now let's talk about, as we wrap up, sorry, my alarm, I have so many alarms. So let's wrap up with the less likely causes of recurrent pregnancy loss. It's important to gain a good detailed patient history because it can help us identify some of the easier workup paths. Now, these are the less likely that we'll see and the more expensive investigations. Chromosomal abnormalities. When a woman has a miscarriage, if you have 100 women, about 15 of them, 15 to 20, will have at least one miscarriage. That's pretty common. But for people to continue having miscarriages only because of chromosomes is abnormal. So up to about 50% of all first trimester miscarriages are secondary to abnormal chromosomes. But for the same woman to continue having losses because of chromosomes is abnormal. Because this workup is very expensive, it's important to rule out other things. So there's different chromosomal issues that can happen, like balanced translocations in the mom or in her partner, and it's pretty complicated. So keeping that in mind, but it's kind of a final step when we ruled out everything else. Now, antiphospholipid syndrome. Antiphospholipid syndrome, When I explain this to patients, I tell them that the blood is like a river, right? That flows throughout your body. And for whatever reason, there's something inside that causes your blood to thicken and causes your blood to have clots. And because of that, those clots can form in the heart, they can form, in the heart, in the lungs, in the brain, and also go to your pregnancy. And it can form in your legs as well. So it's an autoimmune disorder that causes clots and thromboses and thrombi. And again, you can have clots in the leg, you can have a stroke, you can have pulmonary embolism. So a woman that has a history of a lot of clots and a lot of miscarriages, this points to antiphospholipid syndrome. And antiphospholipid syndrome has specific diagnostic criteria. And again, it's good to rule out the other things first, because the laboratory criteria for antiphospholipid syndrome, they do have, this workup can be quite expensive for women. So it's either a positive lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein on 2 separate occasions, 12 weeks apart. Ideally, in some cases, when I do draw up, in the past 10 years, I've had 4 women that were positive for antiphospholipid syndrome. And we just used 1 positive. We didn't wait for the 12 weeks apart because these women actually presented in pregnancy early. The clinical criteria is they have 1 or more unexplained loss beyond 10 weeks, or 1 or more preterm births of a normal baby at 34 weeks that includes preeclampsia or placental insufficiency, or 3 or more miscarriages by 10 weeks. So this is a similar patient that I had that I was suspecting she had antiphospholipid syndrome. She presents like everyone else until you get a detailed history. And she tells you, oh, doctor, well, there was one time I had a clot in my leg way back before I was pregnant. And this happens a lot because this happened way before she even decided to get pregnant. She doesn't think they're related. So her history, again, is like similar to the other women's histories, but she now tells you that she had pain and swelling in her left leg. When she went to the general hospital, they diagnosed her with a deep vein thrombosis, and she needed injections. She wasn't really sure, to help reduce it. Today, she's pregnant, and it's her first ANC visit. So we do the same initial workup plus the antiphospholipid labs. We are checking to see if she's positive for any one of these because she has the clinical criteria, clots plus the miscarriages. And we find out that she actually is positive for lupus anticoagulant. So what does this mean? This means that she is even more hypercoagulable. So this woman, not only she's at risk of having another miscarriage, she's at risk of having another leg clot, she's at risk of having a pulmonary embolus, she's at risk of having a stroke. So this is a very, very high risk patient that should be referred to a teaching hospital. And at that teaching hospital or the general hospital, she needs to start on anticoagulation therapy, which is heparin injections throughout the pregnancy and in the postpartum period. Now, because this anticoagulant medication, this heparin is going to thin her blood, this woman really, 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 this is the kind of person, even during this COVID state, that she needs to follow up with her antenatals very frequently to prevent any issues of hemorrhage. Because as we're trying to prevent clots, we also don't want to induce hemorrhage. So we've come to the end. So in summary, always know what we're talking about in terms of definitions. So recurrent pregnancy loss is 2 or more pregnancies that are lost, and ideally they're diagnosed with blood or urine, but we know that sometimes we just have to use clues that the patient tells us. Remember, there's different causes of recurrent pregnancy loss, and we can distribute this slide to all the facilities to keep as a reference. And so because there's so many causes, you should have a high level of suspicion when you're taking the patient history. If, for instance, chromosomal is happening in the first trimester, there's no other obvious cause. Maybe it's related to the maternal age. Structural is through the physical exam, if they've had a history of multiple DNCs, if they have preterm births, if they keep getting pregnant and keeping the pregnancy but losing it later and later in the pregnancy. Antiphospholipid syndrome, if they have a history of clots. Maternal conditions, poor medical history. Infections, even though we still don't understand how infections play a part, but if you have a history of multiple infections, treat those infections so we can have successful deliveries. RH incompatibility is a very straightforward test. Cervical insufficiency with a good history, painless dilation, loss of LICA, things like that. And then of course, I mean, there's some situations and it's very tough as a clinician. You go through everything, nothing adds up. We have to remember that many cases remains unknown. So management, 2 sections. Some things you can manage only when you're not pregnant, preconception. Some things you can manage during the pregnancy. So typically it's the surgical structural issues that cannot be addressed during the pregnancy. So it's better to catch these women before their next pregnancy. Antiphospholipid syndrome, early anticoagulation, medical management, ideally before they're pregnant, but if they are pregnant and they have poorly controlled conditions, hopefully they book very early and we tackle those problems. And cervical insufficiency, you can do during pregnancy. So here's our list of ladies again. They, on face value, they appear to look similar, but then once getting a detailed history, once doing the investigations, we find out that this patient had cervical insufficiency, these patients had structural issues, this woman had poorly controlled diabetes, and this woman had antiphospholipid syndrome. So what is the most important lesson? Well, patients are people, and we really have to take time and listen to their stories. You know, try, as the patients are telling their stories, we have to weave in and out and figure out how we can line things up and understand what's really going on. Providing reassurance is very important as a healthcare worker, a community health worker, a nurse, a doctor. But the most important thing that we can do, as well as provide reassurance, is create a management plan for success for the patients. And that's it.
Thank you very much, Dr. Anyikam. You have a lot of questions in the chat room. If you stop sharing your slide and go to the chat room and start answering questions, we will quickly hear a case presentation from Dr. Simon Bazioye, consultant ONG department from Island Maternity Hospital, Lagos. Can we make sure that Dr. Bazioye is unmuted? So Dr. Anyikam is going to be answering the questions in the chat, and we're going to address as many as we can on the call, but be rest assured that everybody on the call will be receiving an audio, the video from this call, as well as the slides. And if we don't answer all the questions, you'll be receiving over email the questions and the answers. Over to you, Dr. Bazioye.
Yeah, good afternoon, everyone. This afternoon where I am in Lagos, Nigeria. Dr. Adanna, I hope I got your name correctly. Thank you very much for that presentation. It looks like you have covered everything, but I do have a case here I want to present that really fits a bit of the issue of recurrent miscarriage. We know generally, the studies that have been done all over the world has given the occurrence of this condition as about 1 to 2%. Now, the patient I'm presenting is actually Mrs. She's married. She's a 32-year-old, an actress with the Nigerian film industry, and she's from nearby Ogun State, not too far from where we are in Lagos Island. She's a Christian and she's of the Yoruba tribe. So when she saw us, she was in her 8th ongoing pregnancy with nothing to show for her previous pregnancy experiences. And so she was, she actually came in mid-trimester, but before then we had seen her when she was still about 7 weeks, and she was ordered to do some investigations. Amongst them were glycosylated hemoglobin. She did a pelvic ultrasound scan, including a transvaginal scan. We did have her do antiphospholipid antibody. I'm just going to mention this because it's important for us to realize that for most patients who have recurrent miscarriage, most of them will have normal findings. We couldn't do a karyotype for her. We were thinking of doing that for the abortus she had the last time, but we didn't see her at that time. So we didn't have to do karyotype for herself and her partner. Her partner was not even in the country. So we did all the necessary investigation, including rhesus antibody status and all that. And they all came out with nothing to do about them. They were pretty much normal. There was no indication to why she's been having the pregnancy losses. Now, I would want to mention quickly that in this part of the world where I am, in Nigeria, we do consider age of viability as 28 weeks. Now, she's had mid-trimester losses, and she's had some pregnancies around 28 weeks. She wasn't quite sure of the gestational age, but we just felt we had to manage her as a case of recurrent pregnancy loss, albeit recurrent miscarriage. So our investigation results were essentially normal. And you can imagine with all she's gone through, she's been to several private and tertiary hospitals before she was referred to Lagos Island Maternity Hospital. So when we saw her, we did realize that yes, she does have a burden. She's emotionally distressed. She's really worried what's going to be the outcome of this pregnancy. She's had some investigations in the past that didn't point to any identifiable problem that could be managed. And then when she had investigation in our facility, the same results came up. There was nothing to account for her pregnancy losses. Our gynecological history and all that were essentially normal. Our pelvic scan did not reveal any uterine abnormality. And yes, our pelvic scan did not reveal any abnormality. She had no history of any chronic medical illness, and she was married in a monogamous setting. She neither took alcohol, beverages, or anything, and she was a non-smoker. She had no family history of chronic medical illness. She had no allergies to food or any medications. So examination generally revealed, before I talk about admission and all that, examination generally revealed a fit young woman who was not pale, afebrile, she was not cyanosed, she was not dehydrated. Her BP was normal, her pulse rate was 78. Abdominal examination revealed a 22-week size uterine fundus. And we did do a V, and the cervix was closed. Now, I'll go to the admission now. She had several admissions before we finally decided to deliver her. Can you go to the previous slide, please? She did present in mid-trimester. I hope I did mention earlier on that She had a cervical circlage on board. She did present in mid-trimester with premature contractions. She was admitted and managed conservatively, and then she was discharged in a stable condition. She represented, no, previous slide, please. Sorry, I'm not the one in charge of the slide. I'm not the one doing the slide sharing, but I'll try and make it. She represented at about 33 weeks. That should be 33 weeks and 5 days with labor pains of 7 hours duration. With labor pains of 7 hours duration. And there was no bleeding per vagina. She was not draining liquor. When she had a speculum examination, no cervical changes were noted from what was observed in her previous examination. An ultrasound scan she had done earlier during one of her previous admissions reported oligohydramnios. The biometry was essentially normal. So because of her previous obstetric history, which had several adverse outcomes, she was planned for a cesarean section after completing a course of antepartum corticosteroids to help speed up fetal lung maturity. She did have an emergency cesarean section on account of fetal bradycardia and oligohydramnios the next day. Intraoperative findings were essentially normal. She was delivered of a live female neonate that was in breech presentation. So she had a breech extraction. Baby weighed 2.3 kilograms at birth. The ABGA scores were 6 in 1 minute, 8 in 5 minutes. She did very well. Baby was in the neonatal unit for about 3 weeks, had a couple of blood transfusions. I'm not going to go into the detail of what was found, but it was not related to our obstetric care in any way. And she's presently doing well. The baby is about 6 months and is weighing appropriately and growing appropriately. So in summary, I've presented a case of recurrent pregnancy loss who was conservatively managed, having been investigated with no abnormality discovered, and had a preterm, albeit favorable outcome. Thank you very much.
Thank you very much, Dr. Bazier. Thank you so much. I know we have just a few minutes left, but let's address as many questions as we can. We crave the indulgence of everybody on the call. Over to you, Dr. Anyikam. Let's go through the questions. I know you've answered some in the chat.
There was a question about torch titers. There was a question about torch infections. So torch infections, TORCHES, stands for toxoplasmosis, rubella, cytomegalovirus, herpes, and syphilis. So torch infections don't cause recurrent pregnancy loss. So whenever a woman has these type of infections, the immunoglobulin can cross the placenta and affect the fetus, and it can affect that index pregnancy. So if a woman becomes pregnant again, she has already been exposed and possibly treated with those infections. So it's not a cyclical issue. So if a woman has an infection with one of the torch infections, it can affect that one pregnancy, but it shouldn't be affecting all the subsequent pregnancies. Possibly if she has untreated syphilis, sure. But it's not an issue of recurrent pregnancy loss. It's an issue of pregnancy loss in that one pregnancy. Hopefully that makes sense. And there was a question about endometriosis. It's unclear if endometriosis, that endometriosis can cause infertility, as in they can't get pregnant. But once you're pregnant and you have endometriosis, the literature is unclear that it actually affects the growth of the baby or the development of the pregnancy. Anything else?
Yes, we have the question around, in terms of antiphospholipid syndrome, are there other clotting factors that can predispose to early miscarriage? And what is the role? Okay, go ahead.
What is the role of?
What is the role of MHTFR gene mutation in recurrent miscarriages?
Okay. So antiphospholipid syndrome, those are the three most common: lupus anticoagulant, beta-2, anti-beta-2 glycoprotein, and beta-2 glycoprotein and anti-cardiolipin are the three immunoglobulins that can increase the risk of clotting. MTGFR, methotrexate, methylene tetrafolate, I forget, MTGFR. Whether you're a heterozygote or a homozygote, it's not really an issue of recurrent pregnancy loss. Back in the 90s, there was a lot of research about it, but it's unclear. And if anything, they would say just take extra folate.
Okay.
Hello, can I just... Dr.
Yes, go ahead. Go ahead, Dr. Bazier.
Yeah, thank you. For those patients who you suspect antiphospholipid antibody, if you remember the presentation by Dr. Adanna, those who have had first trimester, those who have had severe preeclampsia, had to be delivered early, things like that. Antiphospholipid antibody syndrome, testing might surface. But for those patients who have had second trimester miscarriages, the Royal College of Obstetricians and Gynecologists would advise, if you do suspect that is just beyond cervical weakness or incompetence, or there's a family history of thrombophilia, you could offer them thrombophilia screening. Now, this will be difficult to get where I practice, but it's just good to have it in mind that apart from clotting problems related to antiphospholipid antibody, the thrombophilias can be screened as well, especially if there's a strong suspicion based on family history or personal history of thrombosis. Thank you.
Okay, thank you very much. I see that Zainab has her hand up. So if you could please unmute her. But while we find Zainab and unmute her, Dr. Anyikam, what do you advise? What do you advise for women with recurrent pregnancy loss for whom all the workup is negative? You can't find a reason.
That's a tough one. It's just reassurance, and sometimes it goes beyond the obstetrician. I mean, these women really need family support, counseling, and then also, depending on if they continue trying to get pregnant year after year, sometimes it's good for a nice reset if they wait. There's no optimal time between pregnancies, but just mentally and physically, if they wait 6 months to a year before they try again. But that's a tough one.
Okay. Is Zainab unmuted now? Zainab, can you ask your question or make your contribution? Okay, while we send a message and ask her to unmute herself, I want to ask this question. What is the role of high dose folic acid and vitamin B?
Folic acid helps prevent neural tube defects, spina bifida. So, and it's not really high dose, it's a specific dosage, but that and vitamin B are not really going to prevent recurrent miscarriages. But it is good to have vitamins, prenatal vitamins. Every woman of childbearing age should be taking prenatal vitamins before conception, at conception, and then in the first trimester.
Okay, I was about to direct a question to Dr. Bazier, but it seems like he stepped up. Do we have Zainab unmuted now?
No,
Dr. Haruna, okay, Dr. Haruna Idris asked to differentiate between pregnancy loss from cervical incompetence and bacterial vaginosis. If we could just wrap up with that question and go to our post quiz. Dr. Anyikam.
So again, Okay, so again, infections, it's unclear if they're really causing this. So specifically in the 80s and the 90s, uroplasma and mycoplasma and bacteria vaginosis were thought to affect the cervix to actually increase cervical shortening. So if a woman has a lot of bacteria vaginosis, but she has a long cervix, then it's probably not a problem. But anytime you see bacteria vaginosis, it's not going to automatically cause preterm labor, but you should also treat it. So if a woman keeps having recurrent bacterial vaginosis, then you should put her on a long-term treatment plan, and then also be monitoring the length of the cervix, because now if the cervix starts shortening, that's when you can implement a cervical cerclage and vaginal progesterone. Because if you just treat the bacterial vaginosis in a woman with a short cervix, the cervix can continue shortening even after treatment and lead to a pregnancy loss. So you have to really be looking at the length of the cervix and put a cerclage in if it shortens.
Okay, we had one question that just came in and is really an important question. So I would like to ask Dr. Harina's question. What is the role of low-dose aspirin in the management of APH?
Low-dose aspirin can be an adjunct, can be added on to the treatment of is it antiphospholipid syndrome, I'm assuming?
No, I think antepartum hemorrhage, if I'm not mistaken.
Oh, well, aspirin interacts with platelets. So if someone is hemorrhaging, you want to avoid anything that interacts with platelets. So with antepartum hemorrhage, there's a whole different protocol. You don't give aspirin for antepartum hemorrhage.
Sorry, she just corrected herself to it's antiphospholipid.
Yeah, that's what I thought. So yes. Because antiphospholipid syndrome is actually pretty deadly, the main treatment is IM anticoagulation. So you need to be on unfractionated or low molecular weight heparin. So the addition of aspirin is plus or minus, but the mainstay is low dose heparin or unfractionated heparin or low molecular weight heparin.
Okay, thank you. Thank you so much. I mean, this call was fully loaded, we'll all agree.